Hello, everybody. We would like to start a session. The time came. So for attendees of the session is named Integrated Care, and I'm going to chair the session. My name is Sonata Mačiulskytė, and I'm presenting our first speaker, Rhoda Macrae. She's a reader with the Alzheimer Scotland Centre for Policy and Practice at the University of the West of Scotland. Rhoda's research interests include dementia education, advanced dementia, and dementia in forensic and prison settings. And she has very intriguing topic, so please, Rhoda, the floor is yours.
Thank you, Sonata. Lovely to see everybody. Good morning. So I'm presenting on how we improve the health and well-being of people living with a dementia in prison. The prison population is ageing. Over 55s doubled in the last decade in Scotland, and older prisoners often have health and social care needs that go unidentified and unmet in this setting. So there has been some work done in dementia in prisons before. The most recent work was done in England, and they found that people over 50, the prevalence rate amongst that group was 6.8%, which is much higher than one would find in a normal community population. Out of those 59 individuals, only 2 had a diagnosis recorded in their notes, which is suggesting that they're either not being screened, they're not being picked up, or they're not being recorded. So the study that we did in Scotland was to try and find new ways to improve the well-being and the health of the increasing numbers of older people living with a dementia in prison. So we went about this by interviewing lots of staff who worked in 4 prisons with the largest number of older people. We interviewed 20 staff about how they found people, what they did when they found them, how did they assess them, how did they support them during the diagnostic process, what happened once they were diagnosed, how did they support them after that. We talked to a whole range of staff, mental health nurses, primary care nurses, GPs, forensic psychologists, forensic psychiatrists, social workers, prison officers, and carers who came in from the community to support people with personal care needs, who had very high levels of care needs. During the course of our data collection, we identified 13 men with a suspected or diagnosed cognitive impairment. They all had multiple comorbidities. Out of the 13, we interviewed 5, and we asked those 5 men to identify somebody else in their life who could give us an insight into their care, their life, and what life was like for them. The 5 nominated nurses and prison officers. 2 men nominated the same nurse. And we also gathered data from their healthcare records to build up a really in-depth picture of their life. To give a little bit of background into how healthcare is set up in prisons, you've got a prison and then you've got a healthcare centre that's situated in the prison. It's not staffed by prison staff, it's staffed by NHS. So the NHS have a healthcare centre, mainly staffed by nurses who have sessional support, people who come in and provide 1 or 2 or 3 sessions a week, people like GPs, forensic psychologists, forensic psychiatrists. So the nurses in the healthcare centres aren't out in the prison all the time. They really only go into the prison accommodation areas to dispense medications. The prisoners come to them for what they need. There's no hospitals in prisons, there's no long-term care facilities. If somebody's sick, they go to hospital. So that means that the healthcare teams are really reliant on the people that are living and working in the accommodation areas to let them know if there's something wrong. Unless somebody comes in with a diagnosis, the healthcare team will only pick them up if they're seeing them for other things, or the prison officers say there's something not quite right, or other prisoners may say it, or the external carers may say there's something not quite quite right with this gentleman, and then they'll go and see them. When they did find somebody, they took a case-by-case approach. So that means that they're really reliant on very committed staff, picking things up and following things through. Assessment in this setting is really complex. As I've described, you've got a healthcare centre with its own processes and systems and IT systems within a prison, and then other community services on the outside. You've also got a lack of clarity about process, and you've got a population with very poor health and often who have traumatic brain injuries. The staff told us that assessing and care was hampered by a number of things. They were short-staffed, they had a lack of clarity about what to do when. The wait times for community services had increased. This happened, the study took place just after COVID, so the wait times had increased quite dramatically. And the staff were feeling really unequipped to work with this population. They weren't their bread and butter population. Now, we only managed to interview 5 men, and that's because 5 of the other men, 5 out of the 13, did not have capacity. They lack capacity to give us consent. So they have advanced dementia. 2 men declined to be interviewed, and another man actually agreed to be interviewed, but unfortunately he had died before we managed to interview him. The staff are talking here about 2 men that we didn't interview, 2 men who had advanced dementia. 2 of the men that we did interview were getting personal care. That means that they had significant health and social care needs. As you can imagine, the built environment's not very flexible, so staff really weren't able to do very much. There are accessible cells, but there are very few of them, and only people that are in wheelchairs that are getting round-the-clock care get them, really. There was attempts to modify cells, and as you can see, one healthcare team managed to do this very successfully for 1 man. Managing stress and distress in this environment is difficult, but the staff tried really hard to accommodate individuals who were agitated. Even if other prisoners were locked up, they would often let men out who were agitated to walk around. However, it wasn't always possible, and sometimes these men became very agitated and the staff perceived them as a threat. So we did hear of accounts where people were restrained. So what happens when they move on? Well, transferring into the communities beset with difficulties, often people don't know their GP until the day they're liberated, or they don't know where they're going to stay either. But sometimes when people are on longer sentences and they've advanced to the point where they need other accommodation because they're just so distressed and their care needs are really high, staff look for alternative accommodation. But there's not really much out there. And they're having to assess risk and care, which makes it doubly difficult. None of the staff were aware of our dementia education that we've had freely available in Scotland for over 10 years. They didn't know about it, but they certainly wanted it. They wanted processes, they wanted to understand who should do what when, and they wanted to understand what somebody may be experiencing. So what we did was we had 3 workshops with lots of staff, people with dementia, family carers, lots of stakeholders, and we got them together and we said, well, what can we do? How can we improve it? So together we have designed a new model and a pathway for pre- and post-diagnostic support. We've produced resources and we're writing reports, and we're going to host them on a website, and we're going to get it out onto lots of organisational websites so practitioners have resources that they can turn to support them in this process. So our high-level recommendations are to implement a whole system model of care, an integrated multidisciplinary approach. That's what the staff say. This needs to be more integrated. Everybody needs to know what they should be doing when they should be doing it. They want education. Dementia education for this group of staff is really important so they can pick up on signs and then know what to do when somebody's presented to them. And the staff were really clear that they felt this would only happen as if there was agency leads in the NHS prison healthcare and the Scottish Prison Service and the Health and Social Care Partnerships. And they felt that these agency leads could lead on the implementation of the model, pathway and education. Thank you very much.
Thank you very much, Rhoda. You were very perfectly on time, so we have more time for questions. Do we have questions in the room? No questions? Let's see, maybe we're having, because the session is hybrid, so no questions, but I was listening to you and wondered, I have two questions. First of all, how did you came to the topic dementia and prison, or dementia in prison? So it's really, we talk in general, but I thought some time ago that, okay, the people live everywhere and they suffer from different conditions everywhere, in prison including. But how did you came with this topic?
I used to work in criminal justice research, and as years have gone on, I became involved in dementia research, and I thought I would be really interested in putting the two together. But I also was really interested in vulnerable populations, and there's people living in our forensic settings and our prison settings with this, and I think that really it's a bit of a triple jeopardy. They're really more vulnerable. They're possibly even more stigmatized than people with dementia, full stop, because they've committed crimes and they're in a setting where really lots of people aren't interested in people in prison. They've committed a crime, why, but they are actually entitled to the same rights and healthcare that everybody else is. And we know that prison healthcare is something that a light hasn't been shone on that for some time, and it's a very difficult setting to provide healthcare in. So I thought that these men would probably be even more marginalised.
Thank you for the answer. Do we have maybe somebody? Okay, we have a question here in the.
Good morning, my name is Chris. I'm a person living with dementia, and I'm a retired police officer. So I've seen some of the unfair things that happen to people in prisons. And my sister worked in the prison. She was a drug and alcohol worker, and she explained the difficulties trying to get help for prisoners with those problems. So to get help for people with dementia in prison, I can imagine how difficult a job it is. And whenever I speak, I say, see the person, because we're all people. We all have the same needs. We all have the same rights. And yet with dementia, you're treated so differently. So I can only imagine how difficult it is in prisons. And I just wanted to say thank you for what you're doing.
Thank you very much. Thank you.
Thank you, Rhoda. I think we can move on, and I'm inviting Maud Graf. Maud is a professor in occupational therapy at the Radboud University Nijmegen in the Netherlands. I'm sorry if I'm wrong to pronounce. Her research line is focused on promoting the self-determination, self-reliance, and participation in meaningful daily and social activities by developing, evaluation, and implementing sound occupational therapy and interdisciplinary interventions in frail people and mainly people with dementia, including people with dementia. So, Maud, the floor is yours.
Thank you. I'm very grateful to be able to present here our study on, it's called Care in a No Man's Land, Perspectives of Healthcare Professionals on Care for People with Vascular Cognitive Impairment and Their Caregivers. So for those who don't know, these are my disclosures. I do receive some funding, but I have no other conflicts of interest. And vascular cognitive impairment, or VCI, is defined as all cognitive impairment associated with cerebrovascular damage, from mild cognitive changes to dementia. So this includes vascular dementia, but also mild cognitive impairment because of vascular factors and also cognitive impairment after stroke. And it's, as many of you might know, the second most common cause of cognitive impairment. So, as you can imagine, because of all these different types of VCI, there's also a lot of different healthcare pathways which these people can follow. So I have some examples from these two people right here. So the person on the left, this man had a stroke, and after a stroke you usually get an acute admission to the neurology department, and afterwards, according to your symptoms, you will be admitted to rehabilitation or geriatric rehabilitation. But these people can also present in quite a different way. So the woman on the right, she might present with cognitive complaints, which in VCI can actually be something else than the memory complaints we've so often talked about at this conference, but it can also be a lack of memory complaints and other cognitive complaints. And because of these cognitive complaints, this woman can be referred for cognitive assessment, and according to the diagnosis will receive dementia care in the primary setting. And as you can imagine, these people will meet a lot of different healthcare professionals along the way, all working with their own guidelines, all having, all working in their own different ways. So it can get quite complex, and there's also a risk for fragmentation because of this, of course. There's also some other challenges that can arise because of these different pathways. So, for example, the person with a stroke, usually after rehabilitation, if its functioning is good enough, the person will return home. But as some earlier studies said, that's when it really begins. So in the home setting, the cognitive consequences of the stroke really surface. The problems in daily life will arise, and maybe people will get stuck after a few years and actually will be referred back to the cognitive assessment at the memory clinic or in a primary setting. But also in the dementia pathway on the right, there are some challenges because there are indications that there are more unfulfilled needs and lower well-being in people with vascular dementia as compared to Alzheimer's disease. So that's why we did this study. Our aim was to explore the perspectives of healthcare professionals on care for people with VCI and their family caregivers. And we asked this to healthcare professionals because they can provide us insight in how to provide care right now and how care is organized. So how do we do this? We did focus group discussions, we did 7 of them, and we did them in primary care, we did them in secondary care settings, and also mixed settings, which means we put people from primary and secondary care together to get a more variety in our discussions. We included a lot of different kind of healthcare professionals, so of course physicians like geriatricians, neurologists, but also the Dutch elderly care physician, which is a primary care-based professional for medicine of older people, but also nurses, case managers, psychologists, and and paramedics, a total of 40. And we analyzed it using our data using inductive thematic analysis. So we transcribed our data, we coded it, and we grouped our codes into different themes according to the Brown and Clark methods. So our results were these 3 major themes in the figure here on the right. So our first theme, which is the orange overarching theme, is knowledge and awareness of VCI. With knowledge and awareness, the rest will follow. Our second theme was about more specific care for VCI. I wanted more specific for this group. And our last theme, which is kind of opposing, but also not really to the second theme, more integrated care across the care pathways. We need to break down the barriers. So I will illustrate these themes with some quotes. Our first theme, knowledge and awareness, was about that our participants felt that knowledge and awareness was a prerequisite for providing adequate care, or as this geriatrician summarized it. Having knowledge of the medical condition, how important that is, that it may come to the forefront very much. And I think if there is awareness, the rest will follow. So of course, knowledge and awareness is very important for healthcare professionals, but our participants also felt it was very important for the general public to recognize VCI more easily. As this nurse said, that people don't recognize it as quickly as, you know, Alzheimer's. So there's less understanding, less recognition from the environment, but a lot of problems in daily life. So our second team, specific care, actually had 3 sub-teams: lack of differentiation, specific recommendations, and specific attention for the caregiver. So the first team, lack of recommendation, was of course about that our participants said there's not really that much differentiation right now in care provided for people with different kinds of cognitive impairments. As this nurse said, there's no differentiation at all in diagnostics and care. It's not really something we look at and think, does someone have vascular dementia? Our second sub-team, specific recommendations, was about the different recommendations our participants gave for some symptoms they found were quite apparent in VCI, or some challenges that were quite often presenting in VCI. Like, for example, this psychologist said, maybe we should take a more assertive approach. Of course, you still want to maintain a sense of equality by allowing someone to make their own decisions or choices. However, when someone is really apathetic, that approach doesn't always work effectively. And the third sub-team, specific attention for the caregiver, it was quite striking to us that our participants kept on repeating that specific attention should be given to the caregiver because, again, they pose some challenges that may not occur in, for example, Alzheimer's disease. So this elderly care physician said, with vascular dementia, you know, it often takes quite a while before someone really deteriorates significantly. I noticed that partners find that very challenging. It's like a sort of no man's land. So our third theme, integrated care, was divided in 2 sub-teams: fragmented care and more collaboration and communication. So as I said earlier, we expected that care for VCI would be quite fragmented, and our professionals did say that it was quite often the case. So they explained that people would be working a lot on their, as they called it, different little islands all on their own. Or, as this neurologist said, there's a communication issue between the various parties, where you end up doing duplicate work. Communication between secondary and primary care could be improved. And as a solution for this, our participants proposed more collaboration and more communication between the different disciplines, the different departments, but also between the different settings like primary care, secondary care, and rehabilitation. And of course, this is always something we want to achieve, but maybe especially in VCI, where there's even more healthcare professionals involved because of all the comorbidities and the different settings in which they can present. So an elderly care physician summarized it this way: breaking down the barriers between settings and healthcare would be very beneficial. You take a much more fluid approach to determining who should be involved in what phase. Currently, we often base it on availability and funding. So what are the implications of our findings? Well, for the first team, knowledge and awareness, there should be more education for professionals about VCI, but also more targeted psychoeducation for people with VCI and caregivers, but also for the general public to make it more known what the consequences could be of VCI. And our participants gave some specific recommendations for care for VCI, such as specific recommendations for symptoms such as apathy or the nonlinear disease course, which can be present in VCI. And as I said, the integrated care for VCI, we should strive for more extended transmural collaboration, for example, further integrating the rehabilitation and the dementia care settings, because there's, from both sides, there's a lot of valuable things that they can learn from each other and integrate more. So what is our next step? We would like to formulate with the professionals and with the people with VCI and the caregivers more recommendations about what to raise more knowledge and awareness of these conditions, so more adequate care could be provided. If you want to know more, you can email me, and I would like to thank my team, and thank you for your attention.
Thank you, Sara. Do you have questions in the room? No questions? Oh, yeah, we have one here.
Yes, first of all, thank you, Sara, for your interesting presentation, for this big room. It's very impressive. I have a question. You have 3 teams you mentioned.
Yeah.
And I'm wondering how much of these teams do you feel are specific for the VCI or maybe more in general for dementia care in general?
I think they are all also general to dementia in general, but they all have their different, what's in the themes. So the specific recommendation for the specific symptoms or the specific attention for VCI, so the knowledge and awareness, what's in the themes is specific for VCI, and I think actually the first theme, of course, we want more knowledge and awareness for the general public about dementia in general, but I think a lot of dementia information right now is mostly geared towards Alzheimer's disease, and I think that that's of course really understandable, but I think that the other side of that is that some things that are atypical in VCI, such as lack of memory complaints or a different disease course, or maybe that they don't act like we think people with dementia would act, something that's a problem that is apparent in this group, but of course also in other non-AD populations.
Thank you. Do we have more questions? No? Thank you, Sara.
Thank you.
Oh yeah. Thank you. I think that we can move on. And I'm inviting our 4th speaker, Björn Schott. Schott is a consultant psychiatrist at University Medical Center Göttingen, Germany, specializing in geriatric psychiatry. He currently heads a memory clinic, and his research focuses on improving the early detection of pathological as opposed to normal neurocognitive aging. So the floor is yours, Björn.
Thank you very much. I would like to talk about another aspect that is highly important but somewhat neglected naturally. That is, how do we care for people with dementia in rural areas? And this particular project that I would like to present today, we were interested in what we could do for people with dementia who are hospitalized for other reasons. As we age, we do not only have increased risk for developing dementia, but in addition, we also have an increased risk to be hospitalized for any reasons, including both medical conditions, injuries, and other reasons. The demographic change is ubiquitous in the so-called developed countries, but if you look at this, you will see that, for example, in urban areas like here, example, city of Dresden, there is still a relatively large population of young adults of the major workforce, whereas in, for example, the rather rural state of Saxony-Anhalt in Germany, you have a much more pronounced shift of the demographics towards the age of 60 and above. So in 2019, the Ministry of Social Affairs, Health and Equal Opportunities of the state of Lower Saxony, where Göttingen is located, put out a call for proposals of improving the situation of people with dementia who are in hospital care. And we proposed that we would establish a dementia consult service. So we, that is mainly Katrin Radenbach, another geriatric psychiatrist in Göttingen, and me. And yeah, we were one of the projects that got selected. So we decided to build this on 2 pillars. One was consultation provided on an individual case-by-case basis, and also a teaching module, which was standardized, and it was multidisciplinary, so it did not only include the physicians, but particularly also the nursing staff. This is where we are located, the city of Göttingen, with about 130,000 inhabitants, surrounded by a rural environment with many small cities, which have small hospitals. And then there's also one facilities specializing on diabetes care. All other hospitals here are primary care hospitals. This one here is marked in green because they only participated in the teaching program due to the considerable distance from Göttingen. They did not receive case-by-case consultations. So, how did we implement this? The first, it always started with the people at the primary care hospitals identifying patients with suspected dementia and or delirium, and they would then contact our consultation service via telephone or email. And this was referred to the consulting physician, who would then contact the hospital back within normally no more than 24 hours, could be a bit longer on weekends, and then we made fixed appointments for consultations either on site or via telemedicine. We used semi-standardized documentation of the consultations, including the current reason for admission, past medical history, medication, other diagnostics such as labs or X-rays if available, and then there was standardized psychiatric, psychopathological assessment. We used the mini-mental state examination to assess cognitive function, the CAM to assess delirium, and then psychiatric diagnosis was made by the consulting physician. So, surprisingly, despite the situation being particularly difficult, remember we got the funding in late 1919, so in 2019, so when we got the funding in late 2019, you can imagine in 2020 we all had a very unexpected event that dramatically changed hospital care all over the world. But nevertheless, despite COVID, we still performed most consultations on site. So that the participating hospitals explicitly still requested us to come in and perform the consultations on site. So, and there was one hospital that requested most of the consultations. They were the hospital that had geriatric wards, so they were most likely more sensitive towards the potential development of dementia among their patients. And if you look at the age distribution, you see that actually almost half of the patients that were seen by the consulting physicians were 80 years or older. Actually, if we can't include patients over 90, more than half were 80 years and older. Particularly among the patients over 80, majority were women, most likely also reflecting differences in life expectancy. The reasons for admission were most commonly, about half the cases, surgical problems, including falls. Medical conditions were also almost equally frequent, and about a quarter to a third of the patients had known neurological or psychiatric problems, and the specific admission for adaptation of pharmacotherapy was mostly due to the inclusion of one hospital specializing in diabetes care. So what were the symptoms for which prompted the staff of the participating hospitals to request consultations? Very commonly they reported general behavioral disturbance or confusion. Increased risk of falls was also quite common, actually as common as obvious cognitive impairment. Sleep disorders or nighttime behavioral disturbances were also reported. So the diagnosis of dementia or cognitive decline was made in approximately half of the cases. In about a quarter of the cases, the diagnosis of delirium was made. Behavioral systems in pre-existing dementia were also rather frequent, and pharmacological questions in about a quarter of the cases. Only in about 8% in 5 cases, suspected depression was the diagnosis made. This is in quite sharp contrast to the history of dementia being recorded in only 9 patients, or about 15%, and pre-known cognitive deficits in 22 patients, about a third. So among the patients diagnosed with dementia, vascular dementia was actually very common, and in 5 cases we had mixed dementia. So among the patients here in the primary care hospitals, the diagnosis of vascular dementia was, of course, it was suspected vascular dementia. We did not, we could not test for A-beta or tau pathology in the consultation setting, but nevertheless, the fact that vascular dementia was actually the most frequently diagnosed form suggests that, particularly, for example, in a hospitalized population, this might be an underdiagnosed condition. I showed you that among the patients, only a small proportion had a pre-known dementia diagnosis. Nevertheless, in the mini-mental state examination, you see that over 40% scored between 10 and 19, which is already classified as moderate dementia. And we also assessed the risk factors, and one really problematic risk factor was polypharmacy. You see that only 4 patients had less than 5 substances, but 20% of the patients had over 15 substances given concomitantly. You can imagine that this will lead to considerable pharmacokinetic interactions and unknown side effects. Risk factors for delirium were also frequent, particularly pain and hearing or visual impairment and surgical procedures. The treatment recommendations were, of course, pharmacological recommendations regarding both discontinuation of problematic substances, change of medications, and if necessary, for also the initiation of specific treatment, for example, against symptoms of delirium. Only in 6 cases, we actually had to admit the patients to our own geriatric psychiatric ward, so the problems for which the consultations were requested could actually be dealt with at the regional hospitals. So I'll skip this due to lack of time. So to conclude, the dementia consultations service is possible to be performed, for example, by a university-based hospital, for example, both by geriatric psychiatric or also neurological units, and it may provide a helpful addition for improving care for patients with dementia in rural areas. And it could also reduce the need for transfers to acute geriatric psychiatry. Limitations, well, this was a unicentric study with no longitudinal follow-up, and we were also limited to regular working hours as we had no emergency consultation service within this project. Last but not least, I would like to thank these wonderful people here, particularly Alexander Kratzenberg, who organized the consultation service and was more or less the good spirit behind it, Katrin Radenbach, with whom I acquired the funding and also did the postdoc research, the physicians, Charles Timeus and Tobias Knipper, Carmen Biscu, a very talented nurse who did very helpful teaching at the participating hospitals, and the students, Jakob and Juliana, who did their thesis as part of this project. And if you are interested in more details, this was published last year in Frontiers in Public Health. So thank you very much.
Thank you, Björn. We have time only for 1 to 2 questions. Do we have questions in the room? Yeah, please, here.
Hi, thank you for your presentation. I'm also from Germany. I think that this topic in telemedicine is very important for Germany now because of policy changes and all the politician ideas. My question is education for the other hospitals. To educate healthcare staff is the one thing. The other thing is have the hospitals some concept or ideas of dementia-friendly hospitals, because to say them what is to do for example, non-pharmacological intervention, but if they don't have any environmental requirements, so how they deal with your recommendations? Are the hospitals prepared for people with dementia in care? They have models on concepts.
Actually, I had to skip that slide due to time reason, but Carmen, the nurse, did some very small but yet effective recommendations. For example, helping patients to find their rooms by placing pictures at the doors, and instructing the ward staff on how to deal with patients who had either a tendency to run away or had a tendency to follow the staff all the time. And these are things that can actually be taught hands-on relatively easily, and of course you cannot rebuild the wards to make them friendlier for people with dementia as easily. There was actually one project also funded by the same initiative where they did exactly that, but that of course unfortunately is often a question of funding and staff to implement such a more substantial change. But nevertheless, small things are helpful too.
Okay, one more question.
Yes, from Amsterdam. Thanks for your interesting work. Must be hard work as well. I was struggling a bit with how can you make a dementia diagnosis when someone is admitted in an acute care setting?
Well, of course, you take the standard approach. That is, you have to take the medical history, and of course, in this case, history by a caregiver is important. Basic cognitive examination, like a mini mental state examination, is possible. And then, of course, you also have to get the important details from the treating physicians at the hospital. For example, are there fluctuations that are suspicious for delirium rather than dementia? Unless, of course, they have been going on for longer, then it could also be Lewy bodies dementia. So it is always a preliminary diagnosis, of course, although let's not forget dementia is a syndrome and not not a clinical etiology, although they could suspect from the context that in many cases it was vascular dementia, for example, if there were few memory problems, if there were pre-existing cardiovascular conditions, etc. But the definitive diagnosis with underlying cause would, of course, require additional workup. And several of these patients were actually later referred for subsequent diagnostic workup to our memory clinic.
Okay, thank you, Björn. We have to move on. And our last but not the least speaker, Emily Spencer. She's a PhD student at University College London. Her research focuses on post-diagnostic support for people living with dementia and their carers, as well as communication within advanced care planning conversations. So Emily, please, we have very short time. I hope that we will be on time. Thank you.
Okay, I'll try and keep it as brief as possible. I'm also not feeling 100%, so that gives me incentive to keep it as brief as possible. So today, I'll be talking about improving the provision of annual reviews and care planning for people living with dementia. And so these are some of the results of the PriDem study. So to give a bit of background, so in England and Wales, everyone with dementia should have access to an annual review of their care and support needs. And within the context of England and Wales, this is provided within the Quality and Outcomes Framework, or QOF scheme, which is an incentive scheme that GP practices can enrol into. And so there's really high reported compliance with the QOF scheme. So before the pandemic, that was around 80% for participating practices. But despite that, the content of care plans aren't well defined, and there's research evidence that suggests that the quality of reviews can be lacking and the quality of care plans can be lacking. So since 2018, the PriDem program of research looked to develop and deliver a new model of primary care-led post-diagnostic dementia care. And in the last couple of years, we've been running a feasibility and implementation study, which aimed to increase the adoption of personalised care planning for people with dementia at the participating practices. So what is the PriDem intervention? So during the initial stages of the programme, an evidence-based intervention was developed, and that comprises a clinical dementia lead, or CDL, who is a nursing or allied health professional background individual who worked with general practices in order to deliver a manualised intervention, which covered 3 core intervention strands. So the first of which was looking to upskill the workforce through delivering training and forming practice dementia teams. The second was to review referral and transition processes in order to develop care systems. And then finally, and kind of the most relevant to this, is to develop tailored approaches and resources in order to optimise annual dementia reviews and personalised care planning. So over the last 2 years, so 2022 and 2023, what we did was we recruited 7 general practices across 4 primary care networks in the northeast and southeast of England. And there was 1 clinical dementia lead recruited to each site who delivered the intervention in practice over 12 months. This was a mixed method study, so we looked at changes to care planning through an audit of medical records, so the electronic GP healthcare records, as well as a qualitative study. In terms of the care plan audit, the aim was to audit the records of 215 patients, both pre-intervention and during the intervention year. Pre-intervention, we didn't use the immediately preceding year because of all of the changes, because of the pandemic. So we used the most recent kind of representative year, which was 2018 to 2019, and then the intervention year was the year of 2022 to 23. And in order to be eligible, patients had to have a diagnosis of dementia, had to be registered at a participating practice, and they had to be living at home at the beginning of the relevant audit period. And just to say as well that these samples were independent of each other, so we looked at a sample for the first year, a sample for the other year. They weren't the same patients followed up over time. In terms of the qualitative study, so we conducted semi-structured interviews with healthcare professionals who were linked to each of the participating sites and looked to include a real range of healthcare professionals as well, so GPs, oh my gosh, I've now forgotten what they were. So GPs, practice managers, link workers, a whole range of individuals. And then we also interviewed people with dementia and carers who were linked to these sites as well. We also conducted 14 observations, so 7 in each of the broad regions, and these were of non-clinical activities that were linked to the intervention. So, for example, it might have been training sessions or meetings in advance of care planning reviews. And we analysed all of this data together using codebook thematic analysis. So in terms of the results from the care plan audit, first of all, our intended sample, as I said, was 215 patients at both time points. This ended up not being possible due to a very high number of ineligible patients at baseline. So we ended up with just 179 patients then, but the full 215 at follow-up. Based on an informal audit before the start of the study, we estimated that 40% of patients would have a personalised care plan. And our baseline sample was very much in line with this, so it was 37.4% of patients that we audited did have a personalised care plan, but this increased really significantly to 64.7% during the intervention year. And so the number of patients with a personalised care plan increased, but also the number of patients with a care plan overall. In terms of the qualitative findings, so as I said, we did a codebook thematic analysis of all of our data, and through that we developed 6 themes. One of the themes is primarily relevant to this question, so I'll be talking about the theme of challenging the status quo, reimagining care planning. So early in the intervention, practices had really varying attitudes towards care planning. So for some, they saw it as really important. For others, it was considered really to be little more than a tick box exercise, and that acted as a real barrier to change for those practices. So here, one of the clinical dementia leads says, in one practice, it was a real struggle to get them to buy into why a dementia review was important and why it was necessary and the benefits to patients and families. And people with dementia and carers that we interviewed were often unaware of their entitlement to an annual review. And the majority of them had never been invited for a review before. So being invited to one through the intervention represented a real new opportunity. So here, a carer that we interviewed said, oh, I had a phone call recently, a month or so back from the GP to say that my husband was due for his annual dementia review. We've never had one before, so that was something new. And going back to the results of the audit, as well as looking at presence or absence of a care plan, we looked at different indicators of personalisation. And across the board, we saw real improvements here. So, for example, whether outcomes or goals were specified doubled, whether outcomes were agreed with the person with dementia and their carer kind of more than tripled. So there were real significant improvements in a lot of indicators of personalisation. There were some that we didn't see as much improvement in, so for example, whether a copy of the care plan had been provided, but we think that's probably likely to be down to what's actually recorded in the notes rather than what was necessarily happening in practice. Going back to the qualitative findings, through the study, practices innovated their own approaches to care planning, and for many of them that was a newfound multidisciplinary approach. And for some practices, the rationale behind that really was to free up time for GPs to shift the work away from them. But in others, it was to harness the skills of the entire workforce. And it often led, through using all of the workforce, to a more holistic approach to care planning. So here, one of the CDLs talks about, we got all of their physical QOFs done, not just the dementia review, but their COPD review, their asthma review, because for people with dementia, their physical needs are really neglected and everything gets overshadowed. So it was really good to get that physical, mental health, as well as their social needs by using an MDT approach. And this is reflected, this shift towards a more holistic approach is also reflected within the care plans that we looked at. So as well as looking at personalisation, we looked at the domains of care that were covered. And again, we saw a real shift towards including more social domains of care. So for example, whether the home environment was reviewed, whether their activities were reviewed, and whether their information needs were addressed. But you'll see that that didn't mean that there was a reduction in things like medication review or physical review. It was just a more kind of holistic approach overall. And for people with dementia and carers, as well as professionals, this enhanced holistic care planning process was really mutually beneficial. So here a person with dementia and their friend say it was very enterprising, the staff were wonderful, because it was really different from anything I'd had at the GP practice, and he went away very, very satisfied. And a GP here, which is a quote that all of our team just love, says, do you know, it's a softer thing. It's like a lot of patients have felt a bit neglected and lost to general practice in the last 2 years. And these are more vulnerable patients. They're the ones that we find most difficult to access. And they're the ones that just, you know, things get worse and worse and they have a crisis. And so proactively reaching them and offering them a comprehensive review has regained some of their trust. And so that's been the real benefit for the practices. And despite workload barriers and time barriers, invested healthcare professionals did view this approach as both feasible and sustainable and transferable to other patient groups. So here a GP talks about how it's an approach that she'll use actually across the board, not just for patients with dementia. So just to finish, to say, this intervention, it succeeded in improving the proportion, quality and consistency of annual reviews and personalised care plans. It was beneficial for people with dementia and their carers who really benefited from a holistic MDT approach. And we've seen evidence of sustainability and impact beyond the original practices that we originally recruited. And this has real implications for the future of commissioning with people with dementia and carers benefiting from that holistic patient-centred approach to care. So just to acknowledge our wider team and our dementia care community, who are some of our stakeholders that helped with this. And yeah, thank you very much.
Thank you, Emily. Do we have questions for Emily for this presentation? Oh yeah, everybody thinks about break. I just have maybe a reflection, not a straight question, but you know how, because to ensure we are always in chronic shortage of staff, and how to balance with this personalized care planning with this, because then it makes like a temporal thing, you know, to do it. Anyway, we return back to routine, and we are again with shortage of staff, and we can't do this. So how do you think how to find balance? Because your findings are very good and results are really promising, but how to ensure?
I think for us the thing that seemed most effective is that involvement of everyone rather than it necessarily just being the GP. And I mean, one of our kind of main themes as well from our thematic analysis was about the pressure that's on general practice and particularly upon GPs. And that was a real barrier. That was something that they found it really hard to overcome. But when there was a meaningful MDT approach, so for example, care coordinators being involved, dementia advisors being involved, who could take on some of that and deliver that really kind of personalised and person-centred care, it wasn't kind of adding to everyone, it was creating more of a kind of equity between those professionals and really working with everyone's skills.
Thank you. I think that we need a short break before the other session. So once again, applause to our speakers. Thank you very much for attending this session, and see you later in the next ones.